Okay.
Okay.
So my presentation will be very short and in general. So if you have any questions, you can do them later, also after the presentations of Dr. Pietro that are more detailed about it. So in general, to start talking about shockwaves and a brief history of shockwaves, in 1971, we witnessed the birth of extracorporeal shockwave lithotripsy. So shockwaves were born mainly to destroy kidney stones in urology field. Some years later, there were the first application of shockwaves on bones in Germany and Bulgaria. So we can start to talk about extracorporeal shockwave therapy in general. And since that moment, there was an increasing use of shockwaves in musculoskeletal diseases and consequent researches on its biological effects. So we can see a change from extracorporeal shockwave lithotripsy, which has a destructive intent, to extracorporeal shockwave therapy, more general, that focuses on mechanotransduction process that allows biological responses. So, more specifically, in this picture, you can see the shape of a shockwave where there is a peak of high pressure and then a negative phase at the end. The peak of high pressure activates extracellular mechanosensors and start this mechanotransduction process that also gives start to intracellular pathways. And these leads to biological effects like reduction of local inflammation, neoformation of blood vessels, reactivation of reparative processes, regenerative effects, and also anti-aging effects. So, to talk more specifically about the CTU S-Wave device, we have a different kind of generator compared to other shockwave technologies. In general, there are a lot of different generators of shockwaves like piezoelectric, electrohydraulic, or electromagnetic, but CTU S-Wave is provided with a diamagnetic generator. So inside the handpiece, there is a magnetic coil that produces a high-intensity magnetic field, and then this magnetic field impacts on the lens that is put at the end of the handpiece, and this is a paraboloid lens that then produces the shockwave and focuses the shockwave inside the biological tissues of the patient. What is different also from other kind of technologies is that the diamagnetic shockwave can be modulated with different shapes. So the other kind of technologies has only one type and one shape of shockwave. With diamagnetic, because of the action of the magnetic field, we can change and modulate the shockwave's shape. We can also have different waveforms, different rise times of the shockwaves. That this gives different effects and different impact on the tissue that we treat. Okay, I speak louder. Then, so in this slide, you can see the different features of the diamagnetic shockwave. And these specific features combined with the possibility to change the amplitude of the pulse and the possibility to control the rise time of the pressure gives a painless treatment. So mainly we can change the waveform and the wavefront from the basic features that you can see written here. And then Dr. Pietro Romeo will talk more specifically about this feature of painless treatment. So, the shockwave CTU S-Wave is focused using the optical principle of the present lens applied perfectly. So there is this kind of lens put on the handpiece, The lens derives from a convex lens in cross-section that is divided into segments, and then the remaining segments are aligned and gives the Fresnel lens that focus shock waves inside the tissue. Here you can see the type of lenses. Please, can the participants put off the microphone? Here you can see the different type of lenses that we can use with our device. There are 4 focusing lenses, and 1 is for the focalized treatment with shockwave. So depending on the number of concentric rings on the lens, we have a converging beam that goes in different depths inside the tissue, as you can see represented here. So it depends on the tissue you want to treat and the depth of the pathology. Here you can see a graphic representation of the different focuses, the different areas of treatment with the different type of lenses. So when we use this kind of lenses to focalize the shock waves, we certainly have the main energy contributions on the central regions of the lens, but also there is a shear strain, so an additional component of energy that derives from the nearest part, the next part to the main energy contribution. And also this shear strain in the near tissue start the mechanotransduction process that then lead to the biological effect from the shock wave. So we can talk about 2 types of focusing. The one is spatial focusing. The second is temporal focusing. So with the choice of the lenses, you can choose the different depth of focalization of the shock waves. And temporal focusing is because with this device you can also modulate, as I said at the start of the presentation, you can modulate the rise time, so the shape, the shock waves, and how it evolves in time during the treatment. Here you can see the screen with the set modes of the device. As you can see, you can change the waveform of the shock wave, so the amplitude and the shape of the shock waves. You can change the wavefront, the rise time, so you can modulate the shock waves in time. You can use the device with automatic or manual modality. You can then select the different energy level of the shots performed, so the power of the shock wave, but also you can modulate the flow of the magnetic field, because you have also to keep in mind that with this device you have the effect from the shock wave, but also you have a part of biological effect due to the magnetic field, the action of the magnetic field. Then you can choose the number of shots you want to use per treatment, and then you can click on Start, Stop the procedure. So in general, we have to keep in mind that this is an electromagnetic device. So as I said, it exerts a double therapeutic effect due to the shockwave energy, but also the magnetic field. And we exploit the magnetic susceptibility of the acoustic lens to produce the shock wave. You can modulate the waveform and the wavefront of the shock wave. So we can talk about temporal and spatial focusing of the shock wave. The treatment compared to other shockwave technology is lower. So you have a low repetition rate of shots. And then what also is different from other kind of generator of shock waves is that the probe needs no replacement or recharge. For example, like piezoelectric in which you have to periodically change the crystals inside the handpiece. And what is also important and very different from other devices is that we have a painless treatment. So the therapeutic applications are mainly orthopedic, like tendinopathies, calcifications of tendons, muscle syndrome, arthrosis, also ulcers, bone fracture delays, trigger points, and other problems. Some of these problems then will be discussed in the presentation of Theofanis that will present to you some clinical cases. So, in conclusion, with this shockwave device, we have a biological and analgesic effects thanks to the shockwaves, but also thanks to the action of the magnetic field. We can have a selective treatment because we can change the temporal focusing of the shockwaves, but also the spatial focusing, and the patient doesn't feel any pain. So thank you for your attention. Dr. Pietro Romeo will start to talk.
Okay, thank you, Federica. Good morning. It's a great pleasure for me to participate to this webinar to better explain, I hope as clear as possible, the main characteristics of this machine. I am an orthopedic specialist and clinical manager in Treviso. As a first argument, I will explain the characteristic from the physical point of view of this machine. The shock waves generated by this machine is a normal shock waves that we can classify as medium levels of energy in terms of MPa, of pressures that can be delivered as the peak pressure of the shock waves. But one of the more characteristic aspects is the negative pressure that is not so in means values like respect to the other technologies. We can see that the negative pressures is up at the minimum 1.7 MPa. It means, and I will explain better this concept, that the pain or the possible damage to the cells is minimum, also with higher intensity of the energy. The main characteristic of this technology is in the generation of the shock waves, in the focusing properties, and in the energy management, Federica explained in her presentations. And all in complex, all these aspects are gives to the machines the characteristics of a painless therapy. At first, we will analyze the generation of the shock waves with these machines, starting from the concept that the machine exploits the diamagnetic properties of the acoustic lens that will focalize the pressures inside the body. In nature, we have ferromagnetic materials that are more reactive to the intensity of the magnetic fields in terms of attractive effect. At the opposite, we have the diamagnetic materials that exert, when they meet in high intensity magnetic fields, and repulsive effect. This means a movement of the lens opposite to the magnetic field. This opposite movement in this machine is utilized to generate the acoustic wave, better the shock waves. A main characteristic of this concept is that the repulsive effect has to be proportional to the intensity of the magnetic fields. For this reason, we have a generator of a very high intensity of the magnetic fields, the Tesla that need to the diamagnetic materials of the lens to generate the shock wave. In this slide, you can see better the concept of the high intensity magnetic fields and the impact with the acoustic lens that generates a normal shock wave. But the characteristic of these magnetic fields is that is a pulsed electromagnetic fields. This means that we have a rise time, a plateau, and a decline of the magnetic fields. For the law of the diamagnetism, in the first part of the impulse, the diamagnetic lens is impermeable to the magnetic fields. In this case, all the energy is employed to generate the shock waves, to move the lens on. Then, during the plateau, the decline of the magnetic fields, the lens becomes permeable to the magnetic fields, and so the magnetic fields flow through the lens. It's a residual magnetic fields, not so high as intensity, but enough to exert in a prolonged biological effect. So for this reason, we have a double biological effect. The first proper of the shock waves, the second due to residual magnetic field. And this is the shock waves that you can have when the magnetic fields reach the maximum, move the lens, and generate the shock waves. As Federica explained, we have as characteristic of an electromagnetic device with a condenser as a storage of the energy and the parabolic lens surface. In summary, concerning the first aspect of this machine, the generation of the shock waves, we can say that CTU shock waves belongs to the class of electromagnetic machines. And this form of energy is different in terms of the effects on the lens that generated the shock waves due to the diamagnetic properties of the lens. With the lens, we can focus the impulse of the high-intensity magnetic fields. It's different the way to focus the magnetic fields because, as you can see, in electrohydraulic, in piezoelectric, and electromagnetic source, we have a linear shock waves. The shock wave is formed inside the lens, that are the acoustic lens, and then reach the focus. And from the physical point of view, we have only a linear shock waves. With the CTU shock waves, we have the generation of the focus acoustic impulse outside the probe. And the generation of the magnetic field of the shock waves is secondary to the movement of the lens. So we have the possibility to focus the impulse, and we have the longitudinal component, the linear component of the acoustic fields, but we have also a transversal component due to the movement of the lens. I will explain better this concept in the next slides. The focusing properties of these machines derives from the application to the acoustic of the principles of Fresnel's length, but this is applied in a different way than convex length to concave length, as you can see here. And the conceptual advantages of the Fresnel's length is that we can maintain the optics and acoustic properties of the Fresnel's length. The concept of the Fresnel's length is that I can have the size of the largest surface of the lens can be, as we can use the term, reduced in the minimal terms, just to with a little aspect to generate the focusing properties of the lens. So normally the dimensions and the depth of the focus can be controlled varying the geometry, the curvature of the lens. And so to have in optics, to have a greater optical effects, you have to use a great lens. Thanks to the Fresnel principle applied to the acoustic lens, we can have a lens, the number of the rings of the diamagnetic lens can control the dimensions and the depth of the focus with more easily than with a great lens. Another characteristic is that the thickness of the lens is only at the maximum and the central part of the lens. In the remaining parts is thin. The lens is thin in the peripheral part, so it can be easy to have a speed movement of the lens when the lens meets the high intensity of the magnetic fields. In summary, the focusing capacity of the CTU shock waves is being at first by the force of the magnetic fields that impacts a thin acoustic lens made of diamagnetic materials, and the characteristic design of the lens made of rings. It gives the possibility to focus the energy in the tissue. The more important aspect of the CTU shockwave machine is the possibility to manage by the operator the distribution of the energy in the focus. As explained Federica, we can have the possibility to modulate the rise time of the shock waves, and this is in accord to the elasticity, the acoustic impedance, and the energy absorption of the tissues. This means that we have to consider that for different pathologies or for different sites of the disease, we can adapt the energy directly to this characteristic of the tissues or the pathology. So we can use an high rise time, for example, for bone or on stiff tissues. We can use a medium rise time when we want to try to treat, for example, the tendon. We have the possibility to use a low rise time just to treat, for example, the skin on the superficial tissues, or better, we can use the setup of the machine for acute phase or the inflammatory phase in tissues. The adaptation of the energy can be better explained in two characteristics when we need an high waveform that are the calcific tendinopathy of the shoulder, in this case of the HeelSpurs in plantar fasciitis, for example. The possibility to change the design of the shape gives the possibility to distribute the energy differently in the focus. So we can have a large distribution of the energy on an intermediate distribution of the energy, or in a narrow distribution of the energy. Again, according to the characteristic of the tissue or to the pathology. Since the design of the shockwaves is time dependent, changing the design of the shockwaves, we change the time in the graph's pressure time. So for the equation of the energy flux density, we can have a different energy flux density in the focus without change the pressure of the energy as happens or as is necessary for the conventional device that produces shock waves. A classical example is this, that if I set a machine in power 10 that corresponds to set values of the pressure, I can change the energy flux density without to change further the pressure, but only changing the design of the lens, that means of the shape of the shock waves. That means the different distribution of the energy in the focus. The waveforms of the other machines can't works in this way, because the conventional device retain immutable characteristic of the shockwave design in a different aspect to the shockwave, the CTU shockwaves. The possibility to change the characteristic of the delivered energy is given by the display of the machines. Here we can change the pressure, and the power is referred to the pressure that the first condenser of the machine can deliver, while the possibility to change the magnetic fields gives the possibility to have a greater secondary effect of the shock waves, that is the modulation of the impulse inside the tissue. Separately from the pressure, here we can see the acoustic lens that produce the shock waves. We have the concave part of the lens that is the most important to generate a focused shock waves. But at the same time, we have the movement of the lens that gives a certain part of mechanical energy nearby the focus. It means that we have not only the focused shock waves, but we have a stimulation of the tissue nearby the focus. So when we modulate the dia, the magnetic fields, when we set the different values of the dia of the magnetic fields, we increase this adjunctive energy that is independent from the focused part of the lens. And as a secondary effect of the great impulse of the magnetic fields with the lens is that when the magnetic fields decline, we have no more power of the shock waves, but we have only the residual magnetic fields that reach the tissues. This can be very interesting in the treatment of superficial tissue on inflammatory states. Another characteristic is the lifespan of the CTU shock waves, that is very different, as you can see, from the piezoelectric, electrolytic, or electromagnetic device, the possibility to have good biological effect with a lower number of the shots. In the way now the attenuation of the probe they use as of course to the other technology. So in conclusion, we can see that the development of the shock waves is a mechanical shock waves with a double longitudinal transverse impulse that produce the shock waves in the central part of the lens, but we have also the characteristic of a mechanotherapy due to the physiological shear strength of the tissue. This is a consequence to this mechanical effect on the tissue during the treatment. We have the possibility to manage so the shock wave pressure and the magnetic field effect. We can change the rise time and the density, the energy flux density inside the focus. We have a singular energy focus mode just to realize a tailored treatment adapted to the tissues and the pathology, and the characteristic from another point of view is the lifespan of the probe. And at the end, the main aspect of this machine, further the efficacy from the biological and clinical point of view, is the fact that it is a painless absolute therapy. Thank you for your attention.
Okay, I prepare now the next. Yes. There are any questions for now? If someone wants to do a question, can activate the microphone or also write it in the chat. Otherwise, we can continue with the next presentation.
Yes, I have a question.
Yes.
We know there are other electromagnetic technology shockwave. Is CTUS wave unique in generating or using 2 Tesla magnetic field?
Yes, yes.
So other magnetic shockwave technology are using lower energy?
Yes, use low energy, but have a different way to generate the impulse of the shock waves, because there are different lengths. At different lengths, they produce a discharge of the energy in the water.
Mm-hmm.
All the machines, the electromagnetic and electrohydraulic machines, need a water circuit to produce the shock waves. From the technical point of view, we have no water circuits, but we have directly the impact of the energy delivered by the electromagnetic coil immediately on the acoustic length.
So we don't have a water circulation system in the CTUS wave.
No.
So
But it's the advantage. It's the advantage because the pressure in the device is not constant. And you can have the same impulse from the fast to the last shot of the lifespan of the end probe of these machines, because you can have variation of the waters. Also, you can have the bubbles of gas inside that attenuates the energy delivered to produce the shock waves. In our opinion, with this machine, the impulse of the shock waves is constant, continuously. It's not the same with the other machines.
So it's also less maintenance in this technology, right?
Can you repeat, please?
So this technology is also less maintenance than other technology.
Yes, yes. Yes, yes. There is only the ordinary manutentions, but not to change the probe on with problems with the problem.
So
I use this machine. I started to use in my practice, private practice, these machines 5 years ago, but I never changed any component of the machine.
So since we produce so high electromagnetic field to Tesla,
yes,
is it health risky for the operator and for the patients?
There are no risks because the electromagnetic is protected by this material that allows only the transmission of the energy here. That is the part where we have a spring that moves the lens. It was tested many times, this possibility, but we have not magnetic fields around the probe. Because the great part of the energy is discharged here and move the lens. And this pulsed magnetic field is not continuous, like MRI, for example. But with this on-off of the pulsing of the magnetic fields, you have a very speed. So you have a time of the exposure very short to produce the shock waves.
Thank you, Dr. Romeo.
Thank you for the possibility to explain this aspect of the machine. Thank you.
So there are other questions? We can move on.
Hello, doctor. Hello, doctor. Can anyone hear me?
Yes.
Yeah, I'm Ben Chan from Hong Kong. Actually, as a clinician, usually we will, when we apply the shock wave to our clients, usually they will feel some pain during our applications, no matter it is from the electric shock wave or the electrohydraulic shock wave. But as you said, this kind of diamagnetic shock wave is painless. So usually we will use that kind of pain to let us know that we are focusing on the right spot. You understand what I mean? If it is painless, how can we how can we identify that they are focusing on the right area and right spot for that kind of patient? Or can you explain to me that would the patient feel anything during the application of this kind of diamagnetic shockwave?
Okay.
That's my question. Thank you.
Yes, come faccio sapere che sono sul punto giusto se il paziente non prova dolore, principalmente la presentazione che c'è dopo comunque.
But I will explain better in the next presentation. Anyway, is not the pain that the patients can feel during the treatment. This is the guide to treat the right part. Usually, I I have as reference the ultrasound examination of the patients and or also the clinical examination and the diagnostic aspect that gives, in my experience, the possibility to treat the exact part. I know the painful part of the tendon, for example, because I made a diagnostic examination to the patients, and I know if it's, for example, pain to the elbow due to tendinopathy. I know that from the diagnostic point of view, the patients will feel pain in that precise point, and this is the area to treat. It's not necessary the pain during the treatment, but the pain when you perform the clinical examination of the patients.
May I know that what will the patient feel when we applying the diamagnetic shockwave?
Excuse me, can you repeat, please?
My question is, what will the patient actually feel when we applying this kind of diamagnetic shockwave?
But the patients feel the shock.
Shock.
Yes,
Okay.
the patient said to me, I feel the shot in the bone, I feel the shot in the pen. It's different to feel pain from the shot of the impulse.
So this is a kind of feeling, shock feeling instead of pain.
No pain, but they feel the impulse that reach the target.
Yes, it's not electrical shock. It's the shock. So you feel the mechanical
the shock of the shock wave.
Yes.
Okay. Thank you. Thank you very much.
Yes, like I don't know if Theofanis wants to add something, but also from his practice, he's writing to me in the chat that the patient feels like a constant finger pushing him during different shocks. So there is this mechanical effect from the patient. It's not pain, but it's an impact on the skin and on the tissue.
It's a perception of the shock wave without pain.
Okay. Thank you very much.
Okay. There are other questions? Okay. Arnold says, will the stronger shock give a better clinical results?
It depends. It depends from the tissue, it depends from the pathology. A stronger shock gives better results in delayed union of fractures, for example, or in calcific tendinopathy of the shoulder, or in plantar fasciitis.
So it's not related if the patient doesn't have to feel pain or a great impact to have a biological effect. Is there any clinical guideline for dosage?
Normally, we have the protocols that correspond to the normal guidelines from various reviews or papers that analyze the best energy to treat the various pathology. So we have, for example, we have no protocols, but the best results that are, for example, in from 0.2 to 0.30 millijoule per millimeter square, for example, in calcific tendinopathy of the shoulder, more than 0.30 for the treatment of bone, for 0 pain to 0.15 for tendinopathies. But this is, we have a range of values because in the market we have a certain number of the machines that are all different, from the energy flux density that is recommended for a selected pathology. It's the same from the C2 shock waves. We have in our method of working, in our user guides, also the table with the possibility to differentiate the treatment, for example, for tendon, bone, skin, and others.
Okay. I don't know if Theofanis wants to add something.
Yes, it's very important to all of us to understand the right time, because we have a basic program that we work with US wave, and on this we do our changing, and depends the patient, as Dr. Romeo said, because each body is not the same with other body. So that means we have to understand very good the right time and the amplitude of the wave form. If we understand these two things very good, and we use the lens that we need, because it's very important, and the lens, we are exactly on the point of problem.
Yes.
And after this, we have to put the normal power of the machine and the diamagnetic that we have to use. So that means that we have not exactly a fixed protocol, but we have a basic program, and on this, as physiotherapists, we do our changes.
Yes. Yes, what Theofanis is saying, that we have to target the therapy. So we have basic protocols, basic amount of energy, and then depending on the pathology and the phase of the patient, we can modulate and target very well the therapy with this device.
Exactly.
But this is for all the machines. I used all the machines in the market, and each machine has proper protocols, but the protocols has to be tailored to the patients, to the pathology, and you have to adapt your knowledge of the machine for the patient. So you have to better understand the electromagnetic machines over the electric arc machines, because, for example, in conventional electromagnetic machines or electrodialysis, you have a different number of shots. You can reach 2,000 shots for an electromagnetics, and respected to an electrodialysis that you can use at maximum 800, for example, in conventional pathologies. It's a fundamental concept. In my experience in shock waves, that from many years, you have consider the guidelines only of the first guide to have the knowledge of the machine, how to use the machine. But in all the technologies, in all the different pathologies, you have to adapt the treatment to the patients. But this is, for this reason, it's important to study and to know the machine that you are using in that moment.
Okay, thank you. Thank you, Dr. So I think we can go on with the other presentations, and then if there will be other questions, we can do it later.
Okay, we continue with the the explanation of this painless therapy in a technology that produces a real shockwave. Shockwave pain is usually related to the stimulation of an inflamed area, to the focal size, the intensity of the energy released in the focus. Usually it's a transient pain, but it gives discomfort. But a difference from the other characteristics of the other machines, also in inflammatory conditions, CTU shockwaves can supply a painless treatment. The causes are the fast movement of the diamagnetic lens, the characteristics of the diamagnetic lens, the design of the lens, the distribution of the energy in the focus, and the low values of the negative phase of the shock waves. The first is the diamagnetic lens. It's composed by series of concentric lens, and during the treatment we have a short contact time. This is important because we have a moderate stimulation of nociceptive nerve fiber endings. So it's a mechanical impulse, a mechanical contact of the lens in the body, but it's very, very short. And on the other part, we have no stimulation of the normal sensory mechanoreceptors on the surface of the body. They are the receptors on the skin, and this is another characteristic of the machine, not only a painless therapy, but the patient has no discomfort from the impact of the lens with the body. This is different, for example, for radio shock waves. Generally, in radio shock waves, we have pain, but it's due to the sign of the probe in contact with the skin of the patients, because we have the possibility with a mechanical pulse of a metallic part to produce an excessive shear strain. This means that with radio shock waves we have an overstimulation of the mechanoreceptors of the nerve endings of pain. But a great part of the strain is the deformation of the tissue resulting from the application of a mechanical force in a direction that is parallel to the surface of the body. So we can see the difference in the shape of the probe, of the mechanical probe of the radio shock waves, and with the characteristic of the lens is larger, the length of the CTU shock waves. This produces a low frequency shear strain, differently from the radio shock waves that we have a more hard shear strain in the tissue. This depends from the law of the physics, because the shear strain gives lesser discomfort when the surface is large. So we can see that the CTU shock waves delivery in the mechanical part of the impulse of the lens a physiological low frequency shear strain, differently from different dimensions of the lens of the radio shock waves that are known to give discomfort and pain to the patients. And as explained in the last presentation, the great part of the energy contribution is given by the central row, the so-called Fresnel's zone plate. We have the maximum of the energy here, but we have a certain amount of the energy that is peripheral. And another cause of the absence of pain due to the high impact of the lens with the body, that is the movement of the lens this is another aspect of the physics of the movement of the acoustic lanes. Is the peripheral part has a faster rotation respected to the central part, and this gives a sort of asynchronism because the movement of the length in peripheral rather than the central part. And this is the physical explanation because the patients have no pain in the focus. Not only, so we have a painless therapy not only in the peripheral part of the focus, we have the greater mechanical effect, but we have also no pain in the central part, in the focus part of the lens, due to the different rotation of the central part of the lens respect to the peripheral part. The result is a non-uniform distribution of the energy between the central part and the peripheral part of the lens that attenuates the sensation of pain. We have also different distribution of the energy in the focus because we can use, for example, in a painful condition or inflammatory condition, we can use the drenante setup on the stimulant setup of the wave form of the shock waves because we have a different distribution of the energy of the focus that is lower respected to a part of disgregante respected to the changes of the design of the shock waves. And the same is for the right time. I can give in the setup of the machine more comfort to the patients is if in inflammatory condition I start with a low rise time, more progressive rise time of the energy respected to a high rise time with a faster increase of the energy. This is not possible for the other technology. And another aspect is the low levels of the negative pressure of the cavitation phase of the shock waves. This is an explanation what it happened when the shock waves deliver the tissue. We have a positive phase and a negative phase of the shock waves. The positive phase is a compression phase. The negative phase is of a rarefaction wave. And the sequence of the positive and negative pressures that characterize normally the shock waves, but this gives to the tissue compressive and the tensile forces, and the last one, due to the phenomenon of cavitation, can damage the cells or give discomfort to the patients. This is due to the production after the collapse of the cavitation bubbles in a series of jet streams that can damage the cell membrane of the cells and so generate inflammation in the tissues. With the C2 shock wave, we have slow negative effect because we have lower values of this negative part of the shock waves, and we have a lower possibility to generate jet streams from the collapse of the cavitation bubbles. We have this clinical study that we can demonstrate the effectiveness of the technology in the treatment of pain erythrosis, the arthrosis of the thumb, and we treat with the level of the energy of 0.9 to 0.11 millijoule per millimeter square of the focus. In the pain assessment, we have a meaningful improvement of the a score of the half time at the end of the third treatment, but no pain or discomfort or the adverse effect during the 3 series of treatments to the patients, despite of the mechanical impact of the acoustic lens. And here we can see the distribution of pain pre and the post-treatment from 7 to 2 of the events values. I have experience in the treatment of the bone with high energy, but without pain in the patients that resolved this, that was treated these young football players for pain in bone marrow edema with osteocondritis of the knee. Normally, bone marrow edema is a painful condition, but with this treatment, the patients had no discomfort or pain during all the treatment of the bone without anesthesia or analgesic drugs. For example, the same when I use the machine in the treatment of the delayed union of the fractures, the patients don't feel absolutely discomfort respect to the other technologies, or as in this case, normally the unrecognized fractures of the scaphoid of the wrist is painful normally, but I can treat the patients without analgesic drug, and I had great results after 45 days with the treatment with the C2 shockwaves in these patients. And the same in treatment of cutaneous necrosis, where the inflammation nearby the tissue is very painful for the patients. I easily could treat the patients around the zone of the necrosis and in the zone of the healing, in the first healing zone, without any pain or any discomfort. So diamagnetic shockwave is different from conventional shockwaves because it's a completely pain-free treatment. And this is possible thanks to the fast movement of the diamagnetic lens, the characteristic and design of the lens, the distribution of the energy in the focus, the possibility to modulate the energy in the log values of the negative phase of the shockwaves.
Can I make a question?
Yes.
If we change the lens during the therapy, for example, I started with a lens of 20 millimeters, and after 40 shots, I changed my lens and I use 30 millimeters lens. I have to change and the rise time and the amplitude of wavefront, and I can have the same result. I mean that if I change the lens, I have to change the rise time of therapy and the amplitude of wavefronts, and I can have the same result.
But if you change only the lens,
I change only the lens,
not the setup of the machine in terms of rise time and amplitude are the same. So you have you can't appreciate the difference with you here. You can't appreciate the difference.
Yes, I know that. I understand what you say, but I say that.
But is you change only the depth of the focus. You don't change any other things. It's the same because only the focus is more deep, but the physical of the first lens is the same of the physical. of the second lens.
Yes. Yes, it was something because I wanted to understand for me something.
Okay. Okay, so we can go on with last presentation on Dr. Knight. Okay.
Okay, biological effect is the more important aspect of all the machines. And this is an evolution in the concept of shock waves during the time, in the 30 years that we use shock waves for medical purposes. We start from the disruptive effect of the kidney stones to the regenerative effect that gives the possibility to treat ischemic zone, for example, due to the neoangiogenesis, and to the future of the regenerative medicine. I think that in the next years we will speak about shock waves as a regenerative, as a part of regenerative medicine, gives the possibility of great biological effect due to these machines. But concept of the pain is related to the old concept of the Stone Age for shock waves, when it was thought that the higher energy would ensure the better outcome. But it was realized that lower shock waves intensity were able to induce tissue regeneration, so positive effects from the biological and no aspect, and no necrotic reaction, no damage in the tissue. And normally we can have good results, except to the bone, with levels of at maximum 0.30 millijoule per millimeter square. However, there is still a residual belief that shock waves must be cause of pain to be effective. We know that is not true, but shock induced wave is the proof that it's not true that the shock waves to be effective has to be painful. From the biological aspect, CT shock waves share the same biological effect of the other machines. It's a different way to deliver and to modulate the energy. That is the main difference from this machine from the others. Normally, shock waves characterized by a brief single pulse with a rapid rise time, high peak pressure, and less rapid decline to the subatmospheric values of the negative phase. As you can see, we have with CT shock wave the possibility to change the rest time. But as machines, we can classify the machine in a medium intensity of pressure waves. So with the higher levels of the machines, we can't produce pain because we don't reach very, very high levels of MPA that are not necessary from a clinical point of view to treat the patients. It's very rare. The 150 MPA are used for kidney stones, are not useful for the treatment of the musculoskeletal tissues, for example. And as I explained in my presentation, we have low subatmospheric values of the negative phase of the shock waves. We know that the biological response of the tissue depends from the machines, and we intend because the difference in focus shock waves respect to the radial shock waves, where the difference of the possibility to converge the energy in the focus and to go deep respect to the radial shock waves that are divergent pneumatic impulse that decay with the energy, in the energy with the distance. So to have a good biological effect, we need to work with focused shock waves, and situ shock waves retains these prerogatives. Shock waves are a form of mechanotherapy that exerts the effects due to specific and established features of the constant pulse. So with shock waves, for the mechanical and the biological point of view, is more effective in realizing the mechanotranslation that is the key aspect of the biological effect of shock waves, because to have a biological effect, we need that the body is able to transform the mechanical energy of the shock waves in a biological response. As explained in the last presentations, with the CT shock waves machine, we have two levels of the energy: a mechanical energy and the focused energy that I explained as transversal energy and longitudinal energy. The most important aspect of the regulatory functioning of the musculoskeletal system is the extracellular matrix. So it's most important not only to stimulate the cell with a longitudinal impulse of shock waves, but it's more important to react with the extracellular matrix. And it's a great prerogative of the CT shock waves. So this is why, because in the external impulses that derive from the behavior, external behavior to the human body, we have the extracellular matrix that is the first receiver of all the impulses, transmit the impulses to the cells, and the cell react in a biological way, but inform also the other cells to what is happening in the tissue. With the CT shock waves, we are able to replicate this fundamental aspect of the cell communication. So, because we can better interact with the first receiver, with extracellular matrix. It's a pure mechanical shock waves, as we can see from starting of the impulse. This is a shock wave in water, the higher intensity in the decline, in the negative phase, in the stop of the shock waves. So we can have a metabolic effect, vascular, cellular, in affecting nerve fibers to treat the pain for the analgesic effect of the shock waves. The angiogenesis, the first biological aspect, the more important, that is at the origin of the ameliorment of the healing of the tissues of the patients with this treated with the shock waves. This form of the mechanotranslation that I explained is possible to better stimulate the production of the new vessels, stimulating the extracellular matrix. So I could treat a difficult case with the CT shock waves. So you can see the necrosis of the skin of the tendons after 6 months completely healed. With shock waves, we can modulate inflammation. That is more important to regulate or to reset the aspect of the chronic inflammation. Chronic inflammation is characterized by the dysregulation of the production of the cytokines in the site of the disease. With C2 shock waves and shock waves in general, we have the possibility to remodulate the decline of the inflammatory cytokines and increase of the anti-inflammatory cytokines. That is another aspect of the starting of the regenerative effect. We studied the cells with the C2 shock waves, and we demonstrated that there is no changes in cell viability. So it's important to consider that the strong mechanical effect is safe for the cells, but also biological positive effect in the position of the extracellular matrix. This is another clinical experience in bone marrow edema in advanced degree of osteoarthritis. In these patients, I can treat the patients without pain and successfully have a series of treatments with high energy. In this case that was asymptomatic after 2 years of the treatment. And the same is the difficult fractures, refractures of the ulna that healed after prolonged treatment with the C2 shock waves. So C2 shock waves shares the same indication and contraindication of conventional device that can be used in all the applications that are stated by the International Society for Musculoskeletal Treatment, excluded the contraindications of malignant tumor of lung tissue in the treatment area, the treatment of the spine in severe coagulopathy of the fetus in the treatment area. We can treat easily in common clinical uses of with tendinopathies, bone pathologies, skin pathologies, and other indications for experts in osteoarthritis, in a series of more complex pathologies, or normally in chronic tendinopathies and bone pathologies. And in conclusion, we can say that the treatment with C2 shock waves is safe and effective to have a good response with our patients.
Okay, perfect. So you can start when you want.
My name is Mountzouris. I'm physiotherapist. I'm from Greece, and I'm here to share with you my experience with CTUS wave in some cases. Our first case is a shoulder calcification, and each patient that we did 10 sessions, 3 sessions every week, and we did and 1 session after the finish of the first 9 sessions. The general program of therapy was the use of TENS, laser, shockwave diathermy on the backside of the shoulder, shockwave therapy, massage, and exercising with elastic band of the shoulder, especially for the external rotators. The S-wave program was 80 shots with the focus lens on trigger points that we have on shoulder, with medium rise time, drainage, diamagnetic 18 and power 14. 80 shots with 20 millimeters lens on calcification with high rise time, drainage, diamagnetic 20 and power 14. 80 shots with 30 millimeters lens on calcification with high rise time, drainage, diamagnetic 20 and power 18. And 80 shots with mini lens on calcification, again with high rise time, with stimulation, diamagnetic 20 and power 14. The result was, I can say that was perfect. The patient after the first day had almost no pain at all. During therapy, there was no pain at all. And the difference that we see between the two photos are in time of 1 month and a half. And we see that we have a very, very good result after the therapy. That we had to say was that during the month of his spouse, he had to do all the program of exercises. We have a second case, again with shoulder calcification, and here we can see the difference between the therapy before and after the therapy. Again, we have the same number of sessions, 10 sessions, and the same program with TENS, laser, shockwave, diathermy, massage, exercises with elastic band, and especially for the external rotators. Okay, we did again 80 shots with the focus lens on trigger points with medium rise time, drainage, diamagnetic 18 and power 14. 80 shots with 20mm lens on calcification with high rise time, drainage, diamagnetic 20 and power 14. 80 shots with 30mm lens on calcification with high rise time, drainage, diamagnetic 20 and power 18. And 80 shots with mini lens on calcification with high rise time, stimulation, diamagnetic 20 and power 14. Here we have another case with an ankle sprain of second degree. We did 4 sessions in time of 1 week, and we used the TENS laser, shockwave therapy, massage, and ice therapy. After the first therapy, there was no edema at all. We used the focus lens stimulation with power 12 diamagnetic 18 and low rise time, lens of 20mm stimulation, power 2 diamagnetic 18 and low rise time, mini lens stimulation, power 14 diamagnetic 18 and low rise time. The result was very, very good, and after 1 week there was no edema at all, and the player started running again. He's a football player. And case number 4, we have a HeelSpurs. We have the period of treatment of 3 or 4 weeks, 3 sessions every week. And we did TENS, massage therapy, shockwave therapy, lasers, exercise and stretching. And the shockwave protocol that we used with S-Wave was the program with the 2mm lenses. We used the 2mm lenses that has S-Wave, the focus lens, and 20mm lens with power 14, diamagnetic 18. And we did 120 shots for every point. 80 shots with medium rise time. And yes, I cannot see it all. 1 minute, please.
40 shots with high rise time.
Yes. 1 minute. 120 shots for every point, 18 shots with medium rise time, and 40 shots with high rise time. We have a clinical case 5. It's a TennisElbow. We did 3 sessions every week for 1 month. Total of sessions 12 sessions. And to every session we did TENS, massage therapy, shockwave therapy, laser, exercise, stretching, and cold therapy after the program of exercises and stretching. The shockwave protocol that we used was with the focus lens on trigger points of triceps and wrist extensions with 80 shots, drainage, medium rise time, power 14, and diamagnetic 18. lens of 20 millimeters and milli-lens at the point of zone with 80 shots, stimulation, low rise time, power 12, and diamagnetic 18. These are some icons on the point that we used the milli-lens. Thank you very much.
Okay, thank you, Theofanis. There is a question in the chat. I don't know if you can read it. Given that multiple modalities were used in treating those cases, how do you know the relative contribution of shockwave to the clinical outcomes? I don't know if you understand the question.
1 minute, please.
So, treating your patients, you did
Yes.
a lot of different treatments. So, how do you know that the contribution of the shockwave is related to the clinical outcomes? I don't know if you can also testify from other experiences that you have in general with shockwaves.
My experience with shockwave was first with a type of radar shockwave, and I always use to these therapies shockwave. And now I changed my plan of therapy, and I decided to use S-wave on this. I didn't change nothing on the points that I use S-wave, but I believe that I use shockwave therapy. But I believe that the type of energy that uses S-wave helps much more, and I have better results than a radar shockwave. I took a lot of information about how works magnetic field and the rise time of S-wave, and I believe that helps very, very much to our patients. So I didn't do nothing different as a physiotherapist. I just changed my machine. I use another type of shockwave, and the fact that it uses another, type of energy, I believe that I had better results from other type of shock waves. It was very, very good that there was no pain at all, and I expected these results because as other colleagues said that we have pain, how we do know that we don't have pain using this wave? It's really good that the magnetic field and the type of transmission, the way of transmission of the energy on the tissue doesn't make pain at all. And this that we see directly is the reduce of pain. And I don't know if I understand good the question, but I hope that I give you an answer.
Okay, thank you. There are other questions. I don't know if Dr. Romeo wants to add something or.
Theofanis?
Yes.
Let me put Arnold's question in another way. If you believe that CTUS wave is very effective and already good enough for those shoulders and other cases, why would you also add in like laser, shortwave diathermy, other modalities? Why not just using the CTUS wave?
Because I believe as a physiotherapist that a machine cannot work only alone. I believe that as physiotherapists we have to do a combination of our tools for physiotherapy, and every machine has his role in therapy. So to a calcification, I used S-wave for the bone, and I used it, and the other things, TENS, laser, massage therapy, to help my patient for his move, for his motion. I help him with his exercises. But the fact, the truth is that as time is passing, and I'm taking much knowledge about this wave, I see that there aren't clinical cases that can work alone. And the other problem is that here, to my country, Greece, when a patient comes here, if I do him only one thing, he will say, "Oh, he did not do nothing to me," because that's because that's the idea, that's the system. This is the one idea, but I believe that when we do a combination of things to a patient, can have better results. With S-wave, I didn't have the problem that I had with the radial S-wave, and the problem was the pain. And because of pain, I had a lot of patients that didn't want to do shockwave therapy. With S-wave now, I have better results because I can use a shockwave with no pain at all. And this is a thing that helps me very much to our therapies. The other the other truth is that now with S-wave we can go to pain zones with our body that with another type of shockwave we could not go because of pain. This is very important for us, and now we can do shockwave therapy to zones that we could not imagine that we should go. It's easier, very easy to use shockwave therapy without fear and without pain, and we can take now perfect results. I think that the use of magnetic field on shockwave is a perfect idea, and we have very, very, very good results to our patients, and we can see it for not even the first day, the second day it's for sure.
Okay, thank you.
Thank you.
Okay, there are other questions?
No, I want to better explain that there is the possibility to work with shockwaves and other technologies. But I think that there is something of a cultural from the health point of view. For example, in Italy, shockwaves spread immediately from the first machines that appeared in the market. And in Italy, we use only shockwaves because are more effective than others. But I think that the protocols of Dr. Theofanis is very correct because he used a low number of shocks. So it was an integrated therapy tailored for the patients because with the technology that is not so much spread. I know that in Greece we use, for example, more diamagnetic fields that shock waves. No, it's in the question of culture, no, because you have this kind of guideline to treat the patients. It's the contrary, it's the opposite in Italy. In Italy, we have not users, so much users of electromagnetic fields, but we have a lot of users of the shockwave machines. But I think that you can work integrating with other technologies. With the time, maybe the Theofanis will use only the CT shock waves for the treatment of the patients. But I think that your protocol was covered.
Thank you.
Okay. If there aren't any questions, I think we can stop here.